So today's agenda is we're talking about the benefit of coaching as a model, as augmenting, as partnership with therapy. And in that, it is about the family getting coaching for the whole family system, because we know that if we're treating one member of the family and the rest of the family isn't doing any work, it doesn't almost matter if they go off, if they do their stuff, if they come back into that family system with all of that history and sinew and the way it works, they are going to regress and relapse. So or potentially. So our goal is really to get the whole family on a journey of well-being. And we do that through coaching. And that's what we're talking about today. And real-time skill building and helping, clients, kiddos learn to build sustainable lives for themselves. So the family coaching model, as I just said, what we're talking about is really supporting those that regularly interact with the person at the center of the mental health or addiction diagnosis. So when we look at a family system and we say the IP, the identified person, has the issue, what we're basically saying is the rest of these four might have issues too, and we need to work with that in tandem. Strategies for setting boundaries. When you start doing this work and you start working with families, one of the things that you hear consistently is, I need to set boundaries, I need to set boundaries. And that is absolutely true. And there needs to be something different from punishing boundaries, not brick walls, more like garden gates that are more flexible, easier to open. And in real time, we can discuss with people when we're coaching, when is the time to keep that gate shut? And when is the time to keep that gate open? We can help with problem solving and daily logistics, in addition to 24-hour support in the moment. So when we think about substance use disorders or mental health disorders, almost every family member starts with, what's happened to our loved one? What happened to them? They used to be transparent, now they're opaque. They used to be predictable, now they're, out of control. And for every one person struggling with a mental health or addictive disorder, we think there's probably 4 to 5 family members that are also impacted and affected. So we've got basically 100 million people struggling with substance use disorders. 25% are struggling with the disorder themselves. The other 75% are struggling with their loved one's disorder. So we have to really think about this, as every family is on a journey. I know, I hear it all the time. I don't drink, I've never smoked pot, I've never done anything. Why do I have to do the work? Why do I have to engage in this? And sometimes it's just like, yeah, you do. And that's the card you've been dealt. If you want a family that ultimately results in forgiveness and reconciliation and a healthy family system, then everybody has to do some work. And so, and while that IP is getting numb or dysregulated, families try to control the behavior anyway. They try and control snippets of behavior that are maybe irrelevant. Instead of reckoning with the disorder as a disease or a factual backdrop, they ignore the opposite and the obvious, and they can take on roles like the recovery police. What does that look like? I am sorry, guys. I do not know how to turn that off. How do I turn? I've got my phone on disturb. Does anybody know how to turn it off into the computer?
Oh.
No. Okay.
Usually if you go into the top upper right-hand corner, there's a do not disturb function.
Right. On your laptop?
No.
On your laptop.
I'm sorry, guys. Okay.
You could always disconnect your Bluetooth and your phone, and that might do it.
Okay. Sorry, this is unprofessional of me. So what happens is that people take on roles. They become the case manager in order to alleviate their own fear. They become, some people call the enabler. I don't use that word enabler. I use the word protector because they're seeking to protect one thing that has the byproduct of protecting something else. And they become the recovery police. So we see what really does happen, however, is that families adjust. We adjust for the good and the bad. When something really good happens to us, we adjust and it becomes the norm. When something bad happens to us, we adjust. And so what happens with parents who have kids who are struggling with substance use disorders, they start adjusting everything. And the best way I know how to describe this concept is an old story. And for those of you who've heard me speak before, I'm sorry, but it's one of my favorite stories. And it started in 1993 when Newsweek came out with an article that said, if you are a woman and you are over 30 and you are single, your odds of finding a man were less than getting killed by a terrorist. And this was true. This came out in Newsweek, and there was this slew of women, including myself, who were miserable by this article. Okay, so I went to visit my brother, and he had a heyday with it. He loved this article, and he was teasing me and poking and ribbing like all good big brothers do. And when I finished crying, we sat down to watch Saturday Night Live, and they, of course, had to do a riff on this. And the riff was a dating game of this beautiful woman picking from the 3 Saturday Night Live guys, picking their noses and scratching their bottoms and belching on the air. And you can imagine this scene, and the name of the dating game was, you've got to lower your standards. And that's in part what happens with families. If it used to be that they didn't accept swearing in the house, as long as it wasn't swearing at them, it became acceptable. If they used to think that they should clean their own rooms, excuses start getting made. Oh, they're so busy, they're having so much trauma. And every time they adjust, they're basically engaging in denial. Every time we lower the standards, we are engaging in denial and making the unacceptable acceptable. So, and this dysfunctional cycle continues because when emerging adults underfunction, if they stop setting their alarm clock, what happens if we've got a family that's adjusted? Somebody else becomes the alarm clock. Mom becomes the alarm clock. Is that the new normal for Junior? You bet. Junior says, I don't need to set my own alarm. Mom's going to come in with hot coffee and breakfast in the morning. And Mom might think she's doing that once as a kindness, and it becomes the new normal. And that goes on. The lower the IP functions and the more the mom, dad, the system functions for him, the more the lower functioning becomes the new normal, until everybody basically collapses. So, and that doesn't even take into account the fact that family members, without the agents of numbing that the IP is using, without understanding what's going on with their loved ones, they start changing, and their old methods of coping and interacting stop working. They feel like they've landed on a strange planet with strange people in their homes. And that persistent stress can have a cumulative impact on the sympathetic nervous system. And it can make people make irrational decisions rather than wise and sensible ones. And you all know this when you're in the field. We think sometimes that the IP is the most embedded in reality, sometimes is the most functional because they're able to look at things. When somebody's brain has become hijacked and their flight or fight response becomes highlighted, they're not making or appearing to make sensible and wise decisions. And that's where we come in. as a coaching. We can walk through, we can join with them, and in joining with them, we reduce that flight, fight, or freeze response. So let's talk about protecting. Again, I don't like the word enabling. I use it as protecting because when we use the word protecting, we are going to the intent of the person, right? So we're seeking to protect one thing. We might be seeking to protect the relationship, keep it smooth, but in not bringing up the issues that are arising, we're really protecting the disorder. We might think we're protecting their futures instead of, calling them on their substance use or mental health disorders, but really we're allowing them to flourish. And that is what the intent is, to protect one thing. The byproduct is protecting the problematic behavior. And we do it all the time. We do that, naturally to protect our loved ones. But it is misdirected and it can result in a continuation of behavior, because every time behavior is made more comfortable, what's it going to do? Continue. The other thing we know is that people do seek to protect their own image in addition to protecting the image of their loved ones. And we see this when we're talking about parent entitlement and treatment. So when I first started doing this work, I started thinking about kids who were, this was a long time ago, and the word was overindulged. You didn't hear the word entitlement back in the day. And now it is sort of like a catchword that we're hearing all the time. And some of that is that we now have a label for behavior that we're seeing generationally. And some of that is that the behavior is actually increasing. So, but that behavior, the entitled behavior that we ascribe to a younger generation, has its seeds and roots in parents. And we see it in these: demand for immediate action after months of delay, requests for lengths of stay inconsistent with clinical need. My favorite was getting a call from a mom who said her son was exceptional and needed a 10-day program for opioid addiction. I was like, nobody's that exceptional. A 10-day program is not the clinical approach for an opioid addiction, but you don't understand how special he is. I'm like, yeah, I might understand how special he is, but I still can't recommend that. Requests for single rooms. Some places that's okay, but there are parents that ask for single rooms in places that don't provide them. Special dietary requests. My favorite, because I am the workshop provider for many treatment centers over the years, was opting out of mandatory family workshops. I love that one, right? Isn't that just say it from the beginning? It's mandatory. You can't opt out. Calling at all hours of the day or night without urgent reasons. And my lesson in boundaries with a particular client came from this. I received a phone call from him at about 8:30 at night. And I said, what's going on? Thinking it was urgent. He said, I just wanted to make sure my Bluetooth was working. And I said, okay, I know I need better boundaries. I can't be that person on the end of the line. So, and looking for specialized clinical services that are not applicable and without clinical need. So again, I have been beating this drum. I've been beating this drum today, and I've been beating this drum for about 20 years. We need family recovery. We need for the families of those who are struggling in our culture, in our practices, to engage with them and stand alongside them. Because parents can become addicted to controlling and rescuing behavior, and teaching when they do that their emerging adults are not responsible for their own well-being, that there are no consequences for choices, that happy is in of itself a viable goal, and that pain and struggle are avoidable. All of these things are not realizable based on how the brain works. Happy as a viable goal, we become desensitized to new stimulus in rapid order, and it stops making us happy almost immediately. You know this with a new car. You know this. We know this. So happy, and this comes from a interaction I had with a mom that I'd been working with for many, many years. And I won't go into the long version of the story, but the short version of the story is, after many psychiatric admissions for bipolar disorder and triggered by methamphetamine, we finally agreed that he needed methamphetamine treatment. And he went to a very reputable treatment program. He was amenable. 24 hours, I got the call. I have to go get him. And my question to her was, why is that? And I had my most unprofessional moment. I was absolutely, the red was moving up my face. And I was really strangling on my words. Now, why is that we're going to pick him up? And she said, he's not happy there. And I lost it, guys. I lost it. And I basically said, well, F happy. Happy needs to become the byproduct of him being healthy. Because when happy is the goal, drugs and alcohol are the simplest way to get there. So let's take happy off of the table and move on to productive and well and compassionate and all those other things that go into being happy. Many people with substance use disorders describe to me that happy has become confused with euphoria in their brain. And so when we're focusing on happy, we're focusing on euphoria to them very often. So what we know is, if we don't teach them, parents can become the barrier to getting help. They become the fixers, they ameliorate the consequences, and they engage in entitled behavior all their own. So recovery begins with the family. Let's look at growth mentality versus comfort mentality. Let's look at being specific with the way we set boundaries, specific, reasonable, enforceable, and logically related to the goal. Let's stop trying to be perfect parents and encouraging people to be perfect parents. And let's look at it from a good enough philosophy, right? The gaps we leave, the vacuums we leave for our children are the ones they will fill. Let's not be perfect. So, and by surviving our kids' anger and frustration in those gaps, we're teaching them to live on a more realistic basis. So let yourselves off the hook. Remember Winnicott, go to good enough. And lastly, in my portion of this roundtable, let's remember progress is messy. What people think it looks like is a straight line. What it really looks like is a real tangled front step, plateau, dip, back to the middle and up, more like a sprung spring than a straight line. Thank you. I'm going to pass it over to Amanda Fialk.
Thank you for that. I'm so glad that you talked about the parent coaching portion, because I have to say that within treating young adults and adolescents, I think that the parent coaching is, the most challenging aspect of the process, and that in order for treatment to be effective, the parent coaching has to be done, and it has to be done right. Otherwise, treatment just doesn't work with this age group. So in my part, I'm going to focus on coaching, clinical coaching of the identified client or the identified patient, and talk a little bit about what that looks like, because I think coaching is a word that has gotten thrown out a lot lately in the past couple of years, and it certainly means different things to different people. And we are really trying to professionalize this idea of coaching and Hence, we call it clinical coaching just versus just coaching. So I'm going to get into that into my section. So when we think about one-on-one work with the clients that we do, at least at the dorm, we are thinking about two different approaches. Every client that comes to us gets a therapist, but they also get a coach, a skills coach. Both of these individuals are licensed clinicians. Both have undergone the same type of training, the same education, have the same experience in the field. In fact, an individual might be the therapist for client A, and for client B, they might be playing a coaching role. So we're all playing these different roles with different clients. But when we look at therapy versus coaching, there are some really, really key differentiators that I think is important to point out. So in therapy, we're sitting in a room, four walls, and there's a very boundaried sort of therapeutic frame. And you're not leaving that frame, because when you do so, it can interfere with the transference, countertransference dynamic. In therapy, you're really seeking to facilitate emotional healing by examining past experiences, patterns, and events. And you are really focused on the transference and the relationship. And it's an unfolding process through which healing and growth occur. Coaching, on the other hand, isn't done within this neat therapeutic boundaried frame of these four-walled, therapy offices. And coaching, in my opinion, and I am analytically trained, I think is much more challenging to do as a therapist than conventional psychotherapy, because you don't have that therapeutic frame, and it does get a little bit more messy. Coaching happens anywhere. Coaching happens in the hallway of the treatment facility. Coaching happens on the sidewalk, walking the client to a job interview. Coaching can happen on a basketball court because the client needs to blow off steam and you're going to have your coaching session there. It can happen in an apartment. Coaching can happen anywhere. Coaching is very action oriented. It is very solution focused versus process focused, like in therapy. It is in the here and now. It is centered on goals, objectives, structure, and accountability. And a coach is the cheerleader and motivator and the person that holds you accountable as well. When we look at young adulthood, I think that young adulthood is a really challenging stage of development. Young adults are complex beings, and they have evolving emotional, social, vocational, and familial contexts. And in order to thrive in this world as a young adult, we really need to help young adults to build resilience, self-awareness, and skills. And what we see is that these clients are often lacking basic skills that will enable them to thrive in the outside world. And many of our clients are coming to therapy not just because of a diagnosis that they were given, or because they're feeling anxious or sad or up and down, or because they have an eating disorder or substance use diagnosis. They're coming to us because they lack essential skills to navigate school, home, relationships, work, and they're stuck. Plain and simple, they are stuck. And it is the skills that will help them to get unstuck as they go on this therapeutic journey and process of undoing and discovering and evolving. So what we find is that doing psychotherapy alone is not enough. Doing coaching alone is not enough. It is having both things done simultaneously, and both providers who are providing the services really working together hand in hand as a cohesive team that communicates daily, multiple times a day, about the client. And this is true whether the individuals or the coach and the therapist work together in the same organization, or whether it is between two organizations. The communication between the therapist and the coach is vital to the process. When I started talking about coaching at the very beginning, I mentioned that, you know, coaching is a phrase that it's a very popular phrase these days. You hear a lot of people talking about life skills coaching or life coaching, and we have found that it is vital to professionalize coaching, and that all of our coaches are licensed clinicians. And we do this for many reasons, but like I said also in a previous slide, you know, of the two roles, coach versus therapist, I actually think that the coaching role is more clinically challenging, which makes it even more important that the person in that role has clinical experience and clinical savviness and is a licensed clinician. What we have found is that it is often during coaching, outside of that conventional therapeutic frame, that clients actually let down those defenses, those very rigid defenses. And it is when their most impactful therapeutic moments occur. And when those moments occur, because you don't always know when they're going to happen, especially with adolescents and young adults, you really want to be able to jump on them because you don't know when the next one will happen. So it's important that a licensed clinician, even if they're playing the coaching role, is available when those opportunities arise. The second thing is that, you know, working on skills can be scary. And we often see way more pushback from the clients in the coaching dynamic than we do in the therapeutic dynamic, because what we are trying to do is help them to develop skills that they don't have and take actions that make them feel slightly uncomfortable. And it is so important that the coach has a very nuanced clinical approach when this pushback happens, so as not to shut down the client, so the client is still able to show up and work through those difficult times. Another reason that we really believe that all coaches should be clinicians who are licensed is that it is important that a therapist on the case and the coach on the case speak the same language. We don't want one person speaking French and the other person speaking Spanish and not being able to communicate or understand what the other one is doing with the client. There really needs to be a common language. And when you have two individuals who are coming from a therapeutic background, it really helps with having that same language, which of course minimizes splitting and all those things that we tend to see happen when there's multiple providers involved with a client case, especially a client who is a young adult, and especially with clients who struggle with some of the diagnoses that we tend to see. And you can go to the next slide, Meredith. In terms of coaching areas, because people often ask, well, what do coaches do? What kind of skills are they working on with clients? And the answer is a lot, but it really varies client to client. We work with clients on the specific skills that they need help with. We get some clients, for instance, who come here and their executive function is beyond intact. They are very organized. They have great time management. Everything is kept to a T, on schedule, as it should be. But they are really lacking in emotion regulation skills or in social skills. And those are the areas of focus for that individual client. We have other clients that come to us and they can work a room and manage any type of social environment, but you ask them, you know, when their next assignment is due for their English class, and they have no idea because their executive function is all over the place. They don't know how to keep a daily schedule. They don't know, you know, which is up, which is down. They are, you know, completely disorganized. And for that client, coaching in the beginning, at least, will really be focused on executive function, time management, organization. We have some clients who really need help with just basic ADLs, especially with our clients who struggle with psychosis, schizophrenia, schizoaffective disorder. And it is a reteaching of certain skills, like brushing your teeth every day, like sleep hygiene, like taking a shower, washing your hands. And these are skills that are taught, practiced, and learned over time. Coaching can be focused on job searches and vocational coaching, and that can be anything from resume writing to interviewing practice skills to, for some of our clients, being terribly avoidant and not wanting to actually walk to hand out a resume to the nearby cafe. And coaching is taking a walk up and down Columbus Avenue and handing out a bunch of resumes and processing the anxiety that comes up as that happens. Coaching can be around budgeting, around academics. What's fascinating is that, well, some of our clients certainly need course-specific tutors, like maybe we had a client taking astrophysics and she needed a course-specific tutor. I would say the majority of our clients actually, in terms of their educational coaching, it's really more in the executive function realm or in the avoidance realm, a lot of school avoidance. Money management is another big area that we see. And then social skills, social skills building, helping clients through coaching to work on expanding their social networks and working through some of their social anxiety. And then, of course, the big one at the end, which was very well covered by Diana, is family coaching and parent coaching. We strongly believe that every parent needs a coach, and coaching is not optional. It's just not. The parents need to be participating in it for the treatment to be impactful. So we tell parents that they get to meet with their coach once a week, and that the first 5 minutes they can talk about their child, and the rest of the 55 they are focusing on them and what they need to be working on. So I thought to end, it's always nice to sort of bring to life through a case example how and why therapy and coaching together can be so impactful when working with a client, and why doing one and not the other tends to not be as effective and not lead to the therapeutic outcomes that we want to see. It's hard to think of examples because there's so many and there's so many fascinating ones, but one of the ones that came to my head was and this is sort of very, very basic, but a client that we were working with who certainly did struggle with a variety of different executive function issues, as well as some social anxiety, some social skills deficits. And she's been in therapy, gosh, probably since she was 3-4 years old. For most of her life, she's been in therapy. And this client is motivated. She's a motivated client who truly is showing up to therapy with the best of intentions and wanting to make changes. But no matter what was discussed in therapy, she would go off into life and not be able to take the actions that she had spoken about over and over and over again in those four-walled rooms that she was in those therapy offices. And she had all the insight in the world. She knew sort of the root causes of the behavior. She understood sort of family of origin issues, and still was not able to take those concrete actions to make changes. And what her life looked like outside of therapy was quite lonely. And it made her feel pretty bad about herself and her place in this world. She lived in a studio apartment that was and I say this, and I'm truly not exaggerating, it looked like a tornado went through it. Just completely in a state of disarray, disorganized, clothes everywhere, food would end up rotting in the refrigerator because, she wasn't cleaning that out. So it would smell. And, this is where she lived. And it was anybody living in that type of environment, that's not going to make them feel good about themselves. And it certainly wasn't a place that she would ever, bring friends to or bring a significant other to, because she was embarrassed by it as well. So it impacted her social life, the way that she felt about herself. And in therapy, she would talk over and over, I'm going to go home. Today, I'm going to clean this part of the room for this many minutes. I'm going to do it. I promise I want to do it. Go back to therapy. Did you do it? I couldn't do it. So that's where the coaching comes in. And coach, therapist, client really work hand in hand to set goals that are achievable, that are not overwhelming, but also are challenging. So we want to get that anxiety sort of level as she's cleaning, as she's sort of making her external environment feel a little bit better. She's going to feel uncomfortable. That anxiety is going to get maybe to a 7 or an 8, but we won't let it spike to a 10, and then we'll help her bring it down. But it was really that team all working together on goals that over time got that apartment clean. And in the beginning, it was not easy because we would get in there and there would be yelling and screaming and don't make me do this. I don't want to do it. It's causing me anxiety. Get out of my place. And a lot of working through those feelings, doing some DBT skills in the moment, distress tolerance, emotion regulation. And it, again, had to be a licensed clinician doing the coaching in that apartment. Otherwise, it would not have been effective. But it truly is an example of, over the course of, I would say, about 6 months. And of course there's lapses. Like there would be times when the apartment would look great when we left, and then the next day we would get there and it would be like the tornado came back overnight and we don't know what happened. But I would say over the course of 6 months or so, we were really able to get that apartment looking different, to get systems up and running to maintain it. Which then impacted her ability to have friends over, to go out and meet new people without being ashamed of the environment that she lived in. Insides and outsides started matching more. But it truly was a collaboration. And we tell the client that they are an integral part of the team. They are the team, but the coach, the therapist, and the client are working together. And then, of course, on the side, there's a parent coach who's telling the parents, do not text your daughter every second asking her to send pictures of her apartment, because that's not going to help the process. So it's a lot of moving parts, but I think that each part enhances the other when it's done the right way and when it's done in collaboration. And it is truly the formula for lasting, impactful change. So coaching, we are fans of clinical coaching, professionalizing coaching, and of course the family and parent coaching as well. It sets treatment up for success. So with that, we will end and we will start our Q&A.
Thank you, Amanda and Diana. That was so interesting and so real and honest about the truth about how things go with the course of treatment for both the client, our identified patient, and their family members. And Diana, clearly you have a lot of fans in this audience, because I was going to add in the chat, you might have seen like people going like, yes, this is like, you were definitely preaching to an audience that gets what you're saying. So thank you so much for your information. So as we're just entering in the next 10 minutes or so, you're welcome to put a question in the chat. You're welcome to turn on your microphone and chime in if there's something that's coming to the top of your mind for Diana and Amanda. And Catherine, I'll just read your question and then other folks can do some thinking about their questions as well. But what happens when a client begins to discuss problems during the academic adult coaching where a subject like science is being discussed? So thinking maybe Catherine is thinking like, I'm not a scientist, like I don't know necessarily how to help. Do you want to speak more specifically, Catherine, to what you were thinking? Is that correct about things like science and not being your area of expertise? Or do either Amanda or Diana have any thoughts about, oh, sorry, Catherine can't unmute herself. Let me see if we can unmute you.
Oh,
Catherine.
okay.
There you go.
Can you hear me?
Now you can.
Yes.
Yep.
Yeah, we have a client that is going through our coaching program at New Frontiers in Learning. I happen to be an IO psychologist. I study work, though, you know, we don't need to have a clinical license for that, but I have a client that is an adult learning science, and he's been paired with an academic coach, and he starts talking about all his problems during a science academic coaching for biology. And I'm just wondering how to mitigate that. We got him another coach as well for his restructuring of beliefs. And we're also recommending that he does CBT therapy. But the problem, the intrapsychic conflicts keep coming up continuously. So, and even when I do like a check-in with him, he still starts talking about all the problems. So I don't want to push them away. I want to deal with them, but what is the best way to handle someone like this?
Yeah, that's a important question. And I think that when you have multiple people involved in a treatment team, it is very important from the beginning to have clear boundaries as to who does what and then who doesn't do what, so that splitting and mixed messages don't happen. So, you know, my advice is always, and we certainly do this, is that at the very beginning stages of treatment, we talk about with the client directly, you know, who the coach is, what their role is not, who the therapist is, what their role is not, and that the therapist and coach are going to be talking a lot. We don't keep secrets from each other. And if you ask us to, we will tell you, no, like that's not something that we do. And we're upfront about that from the beginning so that it's all out on the table, because that's the way that we feel things work. So if in a coaching session, and we get lots of clients, especially you see this with personality disorders, who favor one person to the other on any given day. And let's say they are in a coaching session where they're supposed to be doing academic coaching. So they're supposed to be doing homework and they don't want to do homework. So they say to their coach, hey, listen, I don't really feel comfortable talking to so-and-so, my therapist, about this. But yesterday, my boyfriend did X, Y, or Z to me. Can we talk about it? You know, A, they're bringing it up there probably because they don't want to do the academic stuff that they have avoidance around. But B, okay, great. We don't want to certainly invalidate an experience or a feeling that they're having. So the answer is, wow, that sounds like it was a really upsetting situation that happened to you. And it's really important that you talk to your therapist about it. Why don't you text your therapist right now with me here and let them know that tomorrow when you see them in therapy, this is the first thing you need to discuss. So you're not invalidating that it needs to be talked about, but you're clearly laying a boundary that we're here to do academics. And, you know, if this is interfering so much with your ability to do it in the moment, then text your therapist and ask them to have an impromptu conversation. But this is not what we do together. So I think it's just about being really clear. Would you add anything, Diana, to that?
No, that was a perfect response. Yeah.
Thank you, because
Deborah-
that's what I think we wanted. That's what I was coming from, but I got a lot of pushback that this client wasn't ready to do academia until he dealt with some portions of the intrapsychic conflict arising as a result of not just the newly acquired medication that was a very small dosage, but also the fact that he had broken with his psychotherapist some months ago. And we've encouraged him to go back, because that's how we're going to be able to get through these courses. So thank you.
Mm-hmm.
Thanks for asking that question. It was a really, really good example of the multiple team members and how to manage those tough situations. And the other question that was in the chat box from Deborah is just questioning, you know, are there differences between the approach to coaching between O'Connor Professional Group and the dorm? So Diana, do you want to talk about anything that kind of comes to your mind about any differences or similarities or
Well, I
Okay,
think the
perfect.
similarities are, you know, very clear that we are working on skills. We're working on emotional regulation skills. We're working on ADLs. We're working on all kinds of real life social skills, relational skills, academic skills, organizational skills, enjoyment skills, because we're experiencing quite a few young people with, you know, anhedonia right now. So learning how to enjoy life again. I think one of the things that does differ is that not every person on our staff who's doing coaching is a licensed clinical provider. And when Amanda said that they should be, or in your program, in the dorms program, they are, we have people who have degrees in outdoor adventure. We have people, so we have people who have different educational backgrounds providing different educational or life skill services.
Yeah, and I think that in terms of our model with because we're in a program with some pretty intense acuity, and it is a program where people are playing different roles, that is what works here. You know, in different models outside of this type of treatment program, there's probably more flexibility and room for creativity.
That's right. That wasn't mine.
And
I want that owned. That was not mine. Okay.
Diana has fixed her binging problem, so that's
Oh, I
great.
think
Thank
nobody's called. Yeah.
And Elizabeth points out, you know, that there are times when therapists and coaches are working in different organizations. And so there was some discussion about the communication. And I wanted to just kind of reinforce that and make sure that you all really have an opportunity to talk about how important it is to try and be on the same page, even when there are differences amongst the organizations, or, you know, different kind of policies and procedures or things that come up. So Diana or Amanda, do you want to speak to some of your experiences with that?
So whenever we are working with multiple providers, and particularly in a coaching situation, we are doing a lot of care coordination, making sure that everybody stays on the same page, whether that's a weekly phone call that happens between providers, or a check-in or email, whatever it is. It's really essential. Even to your point, Sarah, when we don't agree with what the next steps are, that we have that conversation, and we do that. Yeah. How about you guys?
Yeah, ditto. I mean, it's also one of those, you know, I don't think that we have that many sort of non-negotiable rules. One rule is that parents have to do coaching. And the other is, you know, when there's multiple providers involved from different agencies, that there needs to be at a minimum a weekly phone call between those providers. Communication is just
Key.
it's key. Yeah.
And I'll just add from my own perspective of being a coach and overseeing the DC dorm that it's a wonderful opportunity to model for the client and the families how to resolve conflict, how to become, you know, aligned with each other, how everybody expresses their own opinion and comes to a place of agreement or understanding with each other. And when we're doing that well, we're really showing clients that it's possible and necessary, and showing those skills to them too, which I think is also an additional coaching component of them being able to watch us do the same thing we're asking them to do out there in their worlds as well.
Absolutely.
We have time for maybe one more question or observation, or a thought that somebody might want to chime in about before we sign off and think about the next few weeks. Well, I'm just very grateful for all of you to be here, and especially grateful for the folks at O'Connor Professional Group for their wisdom, and Diana in particular, your energy and focus around this. You know, obviously all of those years of experience just make this so crystal clear for us, and fortunately clients and their parents and family members can also understand that dynamic that you spoke so clearly about. So really, really helpful. I feel like I want to share this YouTube link with a few people that I'm working with as well, so that they can understand some of the things that you talked about. So, and Amanda,
So I do,
really,
1 second. I
go
do
ahead,
a
Diana.
workbook that discusses much of what we've done. So if anybody, it's got check boxes, It's a workbook. So if ever you want,
So helpful. Yeah. And maybe what we can do, and I'm going to pass things back to Tracy after we talk about, we'll finish this up, but to talk about next week, but, or in 2 weeks actually, and next week with NatSap. But I know Tracy will send an email to everybody who's participated today and who's present, and maybe we can just send even the name of the workbook, Diana, so that everybody has that in their email if they're interested in finding it. So
nice.
on that note, I'll pass things back to you, Tracy, to close us up and talk about next week and the following week, and then and we'll send people off to their 4 o'clock meetings.
Sounds great. Thanks, everybody. It's always so good to see all of you and have you here. Diana, a special thanks to you. I appreciate everything you do and everything you said, not only as a professional, but as a parent who's been through this. I really I appreciate the respect you hold for the parents and the clients, as we do at the dorm. And I think that's why this was such a great partnership on this roundtable. Next week, we will be at NatSap. And so there will be no roundtable on Thursday, but we will be back on February 4th with Balance and Mulaney Rogers talking about intuitive eating. And we would love to see you back, same time, 3 p.m. And thank you all so much.